other semi-credit conferences that we've had. But the reason for this meeting is because of the concern of what are our risks and liabilities and actually management of what we consider to be pediatric patients. As most know, East Jefferson General Hospital used to have a pediatric floor, small wing, that ended about 20 years ago. So we really don't take care of any overnight patients in pediatrics. But the concern is for patients who are potentially under 18, and what are our risks and liabilities? Because the concerns are if those patients are admitted for whatever reason, what are our consultants going to be able to practice and do? Concerns can come from OBGYN when they have young patients who potentially be delivered. They can be from other aspects, orthopedics, older kids who come in with knees infections or something like that on the knee, and then they're going to be admitted, or through the emergency room. And how do you take care of those patients at that age? Now, the concern that we have is, if you're 16 years old and you're 200 pounds, you're really more of an adolescent rather than a pediatric patient, and can we treat that? So the question was asked of several different consultants that we have, what should we be doing, and what is the policy within the hospital? Because there's really no policy as far as age and differentiating that as far as what we can treat. And for that reason, I spoke with representatives from Lamico, and I wanted their input, as well as Steve Pizzo from Lou Williams, who is a defense attorney for physicians, as far as what we should be able to do. Lamico assures me that we are protected for what we have, and actually this is going to be sort of an open meeting where we can ask them questions, and if the ladies, and if Steve wanted to come up and we can pose some questions. I have questions already here, but some of the doctors that sent questions in, they're in the audience, and I'm going to let them ask. If y'all would like to come up. I see Dr. DePaulo over there, so he's going to be first since he's got a bunch of questions. Would you all want to say a little something as far as what Lamico's policies are? Because again, we don't necessarily have guidelines for here, so we want to have the policies with Lamico in general.
Good afternoon. My name is Anita Arnold. I'm an underwriting specialist with Lamico. I've been with Lamico for about 20 years, and I'm sure I've spoken with most of you on the telephone or email or had some form of contact. Thank you for having us here today. We appreciate the opportunity to have a face-to-face meeting and to work on these issues. One of the great things about Lamico is that we don't look for reasons to exclude coverage for claims. Lamico wants to protect its policyholders. The reason we exist is because of our policyholders, primarily our physician policyholders. So we're not looking for reasons to deny coverage. But when we found that this situation was making some of the doctors uncomfortable in treating pediatric patients within your specialty, we want to encourage you to reach out to us. When you're in a situation with a patient that makes you uncomfortable, please contact us and talk with primarily our risk management department about how best to manage the risk. Because you can feel comfortable that as long as you are practicing within the general scope of your specialty, we're not going to look for an excuse to deny coverage when a claim has been filed against you. And if you get into an emergency situation where you're presented with a patient and something has to be done, you have to take care of the patient. The malpractice consequences of not taking care of that emergency patient are much worse than the consequences of perhaps stepping a little bit outside of the scope of your specialty. So please use us. Please reach out to your risk management specialist so that they can answer your questions about what makes you uncomfortable about treating particular patients. So does anybody have any questions about Lamico coverage? Jerry's going to talk a little bit about managing the risk. My area is underwriting, so the coverage questions would come to me.
Well, my first question is, I'm an infectious disease specialist. So most of the time we're concerned about an emergent situation. Routine stuff we don't get consulted on. Anything routine can be transferred out of here for the pediatric patient. But an emergent situation, how does that change anything? Should I document something saying, you know, this is an emergent consult, you know, or should I just walk away and tell them good luck? I mean, I hate to do that. I really don't want to do that, but...
Don't think you should.
Treat them like any other patient.
Okay.
I mean, if there's a reason that you would refer the patient, let's say they're on the list that you would say, this is a referral that I would make normally, but it's an emergent situation. You document that, you stabilize the patient to the best you can, and make a transfer whenever you feel it's appropriate. That's what I would do. I mean, I think that you document that. As far as the standard of care, as long as the infectious disease doctor in your situation would do the same thing, you've documented the circumstances of why you're doing what you're doing, why you're treating the patient rather than shipping off immediately. Then you're fine.
And what about almost, should I talk to the patient or the patient's, you know, mom or dad? Should I say, listen, I'm an adult infectious disease specialist, I'm not pediatric, almost like a consent form. I just want to make you aware that we do not have a pediatric infectious disease doctor here. It's almost like a consent for a procedure. Like, this is not ideal, but this is the best you got in this situation. Should I talk to them about that and document that as well?
I think that's more risk management, meaning that's controlling their expectations. Mm-hmm. So I think that if you right away let them know your situation, this is an emergent situation, I'm going to do what I can do, but then we're going to get this kid to Children's Hospital as soon as it's medically possible and stable, that's always good communication. So they know what's going on, they expect that, and then that keeps the expectations realistic to me.
But from a risk management standpoint, we're covered.
Yes.
Yes, from a coverage standpoint, we have coverage.
But it's about managing the patient or the family's expectations. You don't want someone to just come in and say, oh, we're going to transfer you. Well, why are you transferring me? Mm-hmm. You know, they need to know that they need to go to someone with a higher level of care, if you want to say, or someone who specializes in pediatric population.
Is there any magic age cutoff? I don't think there is.
You see, I got some articles looking at this, and I think it's probably condition by condition from the articles that I've read from urology societies, from pediatric societies. It can be age cutoffs, it can be condition by condition, which they recommend you automatically transfer. So it's patient by patient. And I guess you have a feel for that too. Let me ask you this question. Do you, as a rule, just don't treat any peds in the hospital
so far,
as an infectious disease?
Rarely, maybe we'll let a 17-year-old sneak in. For the most part, our rule is not anything under 18.
See, so that presents a whole other set of problems, because for everybody then that admits a ped into this hospital, there's always the possibility of an infection. And if you know on the get-go that you're not going to treat that kid, then do you admit that patient at all, knowing the kid may have to go to Children's Hospital down the road?
Right.
That's a real concern.
So what is the hospital policy in this now? What is the policy now in terms of adolescents? And what is the intent?
We've admitted 16-year-old patients here before.
Our policy now as far as overnight stay is over the age of 16 and over, we consider to be, this is what the physicians that work with us, it's not a hospital policy either. But the operator is 16 and over should spend the night. Between 13 and 15 is an issue with anesthesia and airway control. And under 12, under those circumstances, they should spend the night. So any procedures are outpatient procedures only. If they have to spend the night, they're transferred to
What is the policy for a kid with fever and up to level of consciousness who is 16 years old in the ER? Not a surgical case.
It's considered an adult for the most part.
And they can be admitted, and that's the concern that we have as far as, the consultants.
So the policy is that the ER doctor will take a 16-year-old with fever up to level of consciousness and call medicine permission. Right now? There's no policy to attempt to transfer the child.
It comes down to that case-by-case type of scenario that Steve's talking about. Is the competency of physicians of what specialties you need. And number one. Number two, are those specialties going to support you? I wouldn't let a kid with fever out of the emergency department without talking to the specialist at all. If you're not going to have that backup, or you need that backup, and you don't admit that patient, you shut it down in the emergency.
Yeah, the issue also when you have an
And
That's a-
that's the
a
thing.
big- that's
So
a
what if
big
the
issue. It's a big
16-year-old,
problem. It's a big
what if the
problem.
16-year-old, is 6'2" and he's 200 pounds? I mean, that's
not-
really.
That's not, the issue is that the solution has to be policy driven. And there's no policy on that now. And we are holding the bag, and with all due respect to Lamico, they will cover the case. But all it takes is 3 cases in a row of a pediatric disaster, and then Lamico will call you and say, look, we need to have a conversation about
Well,
copay.
some of that is also dealing with, the physician that's admitting, that patient, is he or she comfortable with that? But then the concern is the consultants.
I have
Are
never
they gonna
been
do
called,
that?
and I've been practicing here since 2001 to admit a pediatric patient. So I don't know that is an issue. That's why I'm asking, because if the hospital is investigating and exploring, opening up the hospital and inviting adolescents 13 to 15 years old, then there has to be a formal addressing of definitions of what is an adolescent.
And that's part of the reason why this is here. Okay? Absolutely.
And we have to have a staffing rearrangement to have the right people to address those cases. Right now, we'll do it if it's an emergency. If I get a call on a 16-year-old and they say, well, we tried calling Children's and Children's is full and Tulane is full and we need to take care of the kid, we're going to take care of the kid. But that scenario doesn't bother me, because I'm taking care of the emergency. I know that I'm gonna do the best that I can, and given the circumstances, I'm gonna be protected by those circumstances. That's different than to make it a habit of inviting the 13 to 16-year-old kids to come to EJ instead of going to Tulane or Children's, and that's where the concern that the medical staff, at least for my group, that's our concern, because we're the ones that do the admissions.
Dr. Ferber, when you say inviting them to come, is there some talk of advertising, or I'm not sure what you mean by that?
Well, I don't think
admit a 16-year-old and then somebody tells their neighbor, oh, well, when we were ill, we just went to EJ. Oh, we go to EJ too. So just if you make that the precedent, I think that's what
I don't think EJ is advertising right now targets that market.
That's not the market we're targeting.
And so
I do have some concerns about this, because somebody can correct me if I'm wrong. I always thought 18 was the cutoff. If that's a gray area, that's fine. But, even though you've got a 200-pound 6'2", 15 or 16-year-old, their bodies still may be developing differently. They might look mature, they might not be mature. And I did call Lamico about this issue, and they told me we were covered. But I also spoke with risk management, and it was also brought to my attention that if there is an unfavorable outcome, and if it goes to court, they will call a pediatric expert. And so you are going, that's where I think the real
Yeah, you're going to be judged against what's the standards of care for pediatric infectious disease, right? And that's what you.
Correct. But I think the threshold problem from just listening to you all is that you've got a guy right here that says, I'm not going to treat a kid who gets infected in this hospital if he's under 18 years old.
Right.
So what do you do about that? Do you ever admit a kid to the hospital that could get an infection, a nosocomial infection, a day later? What do you do about that? I'm not critical of you. I'm just saying that's something everybody, if you know that going in, do you ever admit that patient unless you absolutely have to because it's emergent? I mean, that's it's a political issue, but it's an issue that you have.
Well, this was brought up because the OB department was concerned, because a lot of their pregnant women are under 18.
Sure.
What happens if something goes south, and they get infected, or they have respiratory failure, the ICU support, and that's kind of where this came from. I don't think they're talking about adding more peds patients here, but it's a real concern.
I think if there's no policy, I think there should be policy that the hospital, to protect the medical staff, that the hospital emergency room, and they can define and agree which age range. But let's just say, for the sake of this conversation, that anybody from 12 to below 12, it's a no-brainer. You have to transfer. But say between 12 and 16, that there's at least an attempt to transfer. That should be the policy. That the ER automatically attempts to transfer that patient, and only when that attempt fails, then you go to your in-house staff, and that thing that goes very far towards creating the scenario that protects the medical staff, we have to take care of those cases.
Yeah, and we functionally do that now, okay?
Yeah, but functionality is not good enough.
But hey, we have very few people like this, but this has come up, and that's the reason why we wanted to have the discussion. And like Dr. DeCardi says, nobody is going to be, staying in overnight if they're under 16. We've done that on adolescents. And so the question is that a little bit different as far as the physiology, as compared to 16 or 18? I mean, what is the magic thing? If you're, 17 years old, 11 months, and then a month later you're 18, I mean, where is the cutoff? And that's the thing, and there's a gray area there, and we all recognize that. And the reason why I want to have this discussion is so that you and all the staff can be protected, so that you feel comfortable that you're not doing anything you're not, feel safe with. Dr. DePaula also had a question. If he recommends something to a patient and says, you need to go do this, this, and this, and the patient doesn't do it, is he liable then?
No. I mean, if you documented, you told the patient to get a CT scan or whatever it is, and you have to do that.
Follow-up, or then infectious disease, pediatric.
Whatever it is, and I think you're fine with that, as long as you document that you gave instructions and you expected that, that's fine.
I'm comfortable with the age being 16. Happy to see 16-year-olds have for many years, and this goes for the office as well, because we get, quote, pediatric referrals in the office, as well. And we have to tell them no. Up until now, we have to tell them no, we can't see anybody under 18. I'm happy with 16.
Now,
Personally.
The ER had a question. Patients come in when they're young, under 16, and I think the answer is obvious with that, but if they have a pulmonary problem, cardiac problem, what are they supposed to tell them? The same thing. Basically, go somewhere else.
Yeah. I mean, I think you got to stabilize them and make the transfer. Once they come into your facility, then you make the transfer when it's appropriate. Yeah. But as soon as you can.
To carve out the patient who comes in, and that's not uncommon to have 16, 17-year-old on a delivery unit. That's not uncommon. So,
what are the youngest patients that you or David see in the office? I think I know your answer.
I had a 13-year-old.
Yeah. Yeah.
We see those in the office.
Yeah. Yeah. And so that's the thing. And so that Dr. Herner, going to transfer them out to another place because the mother is a pediatric patient, and so is the baby. So I mean, that's really something challenging. So they see that there, and the hospital is supposed to support our doctors on staff, and that's the only thing that we want to support them and what we can take care of here safely.
You have pediatricians that do the well baby here, don't they?
That's in the neonatal unit, and so they're not going to do anything.
The older
other
babies,
than
and we don't have like the regular pediatrician does the well baby.
There is no Ray. There's no pediatrician who's going to do that.
Yeah. We do have pediatrician coverage. Family practice service will cover pediatric age range in the hospital. Now, what clouds the situation even more, I think it gets back to what you had mentioned about managing the risk, is the basic definition. The basic definition, we could say 18. I'm not sure where we get that number. The American Academy of Pediatrics considers pediatric age all the way up to age 21. So it's like,
yeah. So
one of the things we ask for guidance from LAMICA is what is the prevailing case law when it comes to treating, but basically that the tweeners, 16 to 21, what standards are you going to be held to this and that?
And to be honest with you, Ray, I haven't been doing this 40 years, I haven't had that case yet. So it's not a common occurrence where it's a big issue in my world.
And I will tell you that at Children's Hospital, once they'll treat up to 21, a few exceptions beyond that, anything once they're older than that, even myelodysplastic and everything else, basically they're out the building now. So they're not taking care of them any longer.
Richard, what's the percentage of nurses that we have here who are pediatric advanced life support certified?
The only people they have are going to be, do we have that? Ray, I know we have that in the one-day stay and in an ER. That's it.
ER and same-day surgery. So none of the specialty care, ICU, CCU, specials, cath lab, we don't have nurses who are able to?
No, none.
Are we liable if then we
treat somebody emergently and we don't have advanced life support certification? Should that come
It
forward?
depends on
Would
the
that be-
circumstance. I mean, if it's emergent to the point that you can't transfer because you can't stabilize, then I don't see you have any choice, and I think the standard of care would be just that, okay? If you make a decision that you want to keep the patient but you could have transferred, then I think you better have all that in place, and if you don't, you have exposure. That would be my answer.
Stupid question. Is there a pediatric gynecologist? Are there pediatric gynecologists in America?
It's not an official fellowship. It's something with a gynecologist, and so it's not one that goes through pediatrics per se. Here in the state of Florida, Louisiana, Dr. Tupac practiced as a pediatric gynecologist, so I don't think she would be necessarily a formalized fellowship or have this certification. So it's not necessarily a pediatric gynecologist.
Per se. But there is a training program for them or not?
Unofficial.
Unofficial.
Yeah, unofficial.
How many pediatric, you said just one pediatric gastroenterologist in one?
She's more,
No,
she's in
pediatric.
I mean, pediatric gynecologist.
Pediatric gynecologist, we have Dr. Tupac Pizzo at a children's hospital office, but she's not necessarily trained. She's a normal training.
What happens if a 13-year-old gets admitted to the ICU and you put a consult to the pediatrician that's doing web-based? Just because they're 13.
We're not going to admit.
What is the pediatrician going to say?
There's no pediatricians on staff to see the patient.
Well, the pediatrician is.
It's only a neonatal unit.
What
That's
does
their
that
credentialing is only for that.
The credential is only for neonatal, or they credential? Is there a department of pediatrics here?
Admitting to the hospital? No.
We have a division.
Huh?
We have a division, but I can, they just see them on the fourth
They're not.
floor.
They're not. They're
So
not.
why are they
admitted.
not allowed to? Why are they excluded from admitting? Just out of curiosity.
Because we don't have a pediatric floor to admit the patients. And again, what is the definition of pediatrics? Is it that adolescent group?
Well, that answers your question right there.
Yeah. So
Do
you
we
see,
have no
and
business
that's the
admitting-
thing what Dr. DeCardi said in the beginning. People who are under 16 don't spend the night in the hospital.
I know, but this scenario. This is the scenario. We know all of that. That's the policy. But the patient, they try to transfer the patient. They can't transfer till the patient gets in ICU, 14 years old with something. And instead of consulting the hospitalist, they say, let's consult the pediatrician. We know that can the pediatrician come and see a consult if it's admitted to medicine or GYN?
I don't think they even do that, right? I mean, I think that they go.
I'm going to give you, Ricardo, I'm going to give you an example. Post-Katrina.
They're not bound, they don't have to see a consult. There's no unreferred call for full consult. And it's up to the discretion of the pediatrician.
But family practice could do that.
Okay, but what do you think the pediatrician would say?
I can tell you.
I don't want the responsibility of taking care of this patient in an adult medicine hospital.
In the recent past, what they've told us is transfer the patient to children.
I can
Under
tell
that
you,
age.
Post-Katrina, I used to work at Children's Hospital, LSU, and here. And we used to do the club for the vascular malformations. People from all over the state and Mississippi will come up here. One case that I had to do, it was a 14-year-old girl with renal hypertension. And I did the angiogram with Castaneda, and basically the patient became hypotensive because of the renin-angiotensin system triggering the hypotension. We don't have the facility to treat a pediatric patient. So immediately after same day stay, we transfer immediately the patient emergency to Children's Hospital. Simple as that, I can tell you that. Because we don't have the infrastructure to a pediatric nurse, the dose of medication, pharmacy, and the spatial doses that you need.
So why don't you do the surgery here in the first place?
It was an outpatient facility type of procedure that it was just only a simple angiogram and treat that.
An
And it
outpatient
turned out to be
facility,
something.
but
So
that wasn't
from
here.
there on, we were not able to treat patients that they were 16 years old and older. So all the cases that I had to do them in Children's Hospital. And there was nobody.
ENTs here to selecting some kids.
Do they do it? Yes.
So what happens if a child
You transfer to children.
If they had an issue, they'll transfer them. But they can get to Airways. That's what they do, and they can do it, and they can pack the patient and send them. But the nurses in the one-day stay, they're qualified in order to do that. Now, and that's really the extent, of the pediatric, real care that we have.
What about our OB floor? Is our OB floor, since that's what this all is, do nurses on OB have pals?
No. Only in the NICU, that's it.
And they got something
Again,
24/7, right?
20 years ago, there was a place, but that was 20 years ago, and it was completely different, and that's it.
So the big thing here is that, I don't know if somebody has a pediatric patient in the clinic, can they plan on having them have their OB care here? That would be the only big plan thing we're talking about, right?
Below a certain age, I don't think, you can ask, Dr. Herner or Dr. Bilbos, but I don't think y'all delivering anybody younger than, what's the youngest age that y'all have delivered in the last 10 years here? Electively. And that happens. They get a lot. So what if that problem has a pulmonary problem? What if they go into distress? They know your phone number. They're going to call you. And so I know what you're asking. That's what you're going to be. Because those people can potentially can have that. They're high risk as it is to start with.
Right. But what we're saying is, as a specialist, whether they have an ID issue or they have an endocrine or whatever issue, the emergent stabilization of the patient, all we have to document is these are the circumstances in our hospital. This patient currently is too unstable to transfer. I am acting as the only available person. You do it, you document the hell out of it, and then as soon as they're stable, we transfer. So essentially it's unexpected things, and we just have to well document as soon as they're stable, they get transferred.
I don't think they've ever transferred any patient out from the OB at that point, but that doesn't mean it can't happen tomorrow.
No, if a 16-year-old ends up
having severe
complications and ends up on the
you can get consulted, yeah, but it wasn't,
I mean, we have seen patients in the OBGYN unit that are sick, whether it's a PE or DVT.
At what age?
Below 18.
Below 18?
Yeah.
But below 16?
But it's very rare, and we do it as a courtesy because they're already admitted to OBGYN.
Right.
We're not going to leave the doctor hanging, right? So we come and we help. But if it was something that EJ made a decision to target that age population and invite them to come to EJ, and that this is going to be an expansion of what we normally do here, then I think that requires a more serious look at that in terms of the medical staff and what adjustments need to be made to accommodate that more consistent portfolio of patients. I mean, we definitely would have to have, pediatricians that are committed to coming and doing consults here. Maybe even, pediatric hospitalists if we're going to be admitting patients, in that age range. So that's the concern that we have is that we don't want to go down a slippery slope of being tempted to target a market without thinking it through.
The hospital's not trying to target that market, okay, at this point. That's not even there.
We'd be sending these people to Lakeside 6-7
Yeah.
months anyway, right?
Yeah.
When that comes through.
Yeah.
What about credentialing? Does that affect the same thing if I'm only credentialed for adults? Because most of us here are only for adults.
Does this say only for adults on it? I don't know that it does.
Our boards are for adults.
Your boards are for adults.
Yeah, but
I know in certain specialties it doesn't discriminate that. In urology, we specifically have it for adults and pediatrics.
What about like the hospital exposure though? If they're credentialing us for adults and then we go outside of that, it means that's a risk for the adults. I mean, I don't know if we are or not, but that could be a problem for EJ.
Sorry, I didn't hear what you were.
No, I'm just saying if they're credentialing us for adults,
Yeah, that's
and then we're doing P's, that may be exposure risk for the hospital itself for credentialing us.
Yeah,
not
once
credentialing
the
us.
hospital finds that out, once they're aware of that, they got a problem. if that's happening right.
we-
If it's an
we
emergent
will-
basis and you have no choice, but you got to take the patient's going to die,
Yeah.
then nobody has a problem. I mean,
Okay,
that's
so
what
if the
we're
emergency
doing.
situation,
Yeah,
you just
right.
document.
But I
this.
think the bigger problem is, I'm just listening, so you're going to take a 16 or 15-year-old kid and deliver a baby. Okay, you now know that infectious disease he'll take the consult on an emergent basis, but otherwise you really don't have support of the referrals that you might need. Probably don't, but maybe you do on one or two occasions, and you knew that going in. When you put that kid in voluntarily here to deliver that baby, you didn't have pediatric support for certain emergencies, and that's an issue. That you're perfectly qualified because OBs all the time treat 15-year-old kids, so there's no subspecialty that you refer to. But infectious disease or whatever else you got, I don't know the answer, but I can see where that's a concern to me.
And also, the individual, you credential for the procedure, they don't have delineation on, correct me, on age of the patient, if you can do that procedure.
I'm not sure that it's outlined that an ID is just adult. We'll look at that. But certain departments, have adult, clearly delineated adult and children.
Next, we'll have to look into that.
We'll have to look into that because, that is a very legitimate question as far as the liability risk and credentialing on the part of the hospital, absolutely. And again, then it comes down to what Ricardo was saying about what's the age group that we're going to feel comfortable with the treating. Is there such a thing as an adolescent age group that you're going to be comfortable with?
In some of the articles that I've just dug up this morning, they talk about how much training you have to have if you're not a specialist, how many months you've taken in school. I mean, they get into certain qualifications that you're supposed to have if you're going to take this on.
Is that adolescent or pediatric?
Pediatrics.
Well, let me
Pediatrics.
give you another perspective along that line.
Sure.
If you are a board certified internist and you stay in your office for 3 years, you can't get credentialed here without having a doctor follow you around for 30 days, 60 days. So that puts you in perspective the issue about how frequently you are managing these cases. So if you use that yardstick, we're asking to see pediatric patients that when's the last time we see one every 3 years? So that would automatically trigger the yardstick of, well, you shouldn't really be seeing that patient, because we feel that if you're only a bona fide internist, we're not going to let you manage an internal medicine case in the hospital without supervision because you haven't done one in 3 years.
What age group, Brian, or you, Joe, would you see in your office as far as the youngest?
I'm seeing maybe kids at
17.
16.
16,
Rare
17.
16, but 17.
12 and above is what I have.
You've seen 12 and above.
Yeah, but they usually don't end up in the hospital.
Right. Yeah. So you see, it's all over. I mean, as far as it's all over. So what are we going to do to have something here, that everybody
The
feels
other thing that I
comfortable
was thinking about, I think pediatrics is going on internal medicine. They do office only, they don't do hospital. When they send a kid over to children's, they don't see them.
They do not.
Right, so
You're
even
absolutely
if you have
correct.
pediatricians on staff, they're not coming to see the patient.
And that's one of the reasons why it stopped here, because we couldn't get pediatric coverage for that. Because if a kid comes into the office, they got a stiff neck. Man, they punt so fast, it's unbelievable.
I can tell you from Oshner, they're not coming. My wife's a pediatrician over there, and I talked to her, and they're saying, no, strictly 4th floor, that is it. That's their policy, the Oshner.
Neonate, that's it. They're not going to do anything else.
You talking about Baptist? They don't have Baptist. What do they do at Baptist?
They just go to the delivery units and stuff. Now, anywhere they admit to, they have hospitalists already there. Right. So their group, their only office in seeing healthy newborn babies. If it's not healthy, they go to the NICU, that's the NICU specialist.
So they have a hospitalist pediatrician?
Yes, but at those hospitals. So we don't have that here, so they're not coming here. Outside, for the regular patients.
And do they have a pediatric ID doctor who sees them? Or is it?
They probably put them to the main campus.
Somewhere, yeah.
It's
actually, I don't know if Oshner definitely has one or not. LSU's got Dr. Steele, or he went somewhere. Where's Steele at? Anyway,
they don't have many.
They don't have many. They have
very few. Just like
three.
pediatric endocrinologists, something like that.
Yeah.
Those are rare breeds.
Yeah. I guess family practice would be the closest thing that we got. So.
And they're trained in doing that, but you know, they don't get that many
Yeah.
customers coming in here as far as that. So, you know, that's one of the things that I think we have to look at and decide, you know, what's going to be, you know, can we treat adolescents? And we've been doing it. And we haven't really gotten into any problems yet.
Richard, how active is the Lakeside Hospital? Is it Lakeside Hospital?
Tulane moved their
It is a
children's
children's
pavilion to
hospital,
Lakeside,
right?
so they do everything over there. Yes, all the pediatrics over there. And that's a lot closer than it is up by State Street.
Do they have an ICU for children?
I think they do. They have that whole thing.
I can't hear you, I'm sorry.
What can't you?
No, pediatric. Do they have a pediatric
But I
ICU?
mean, by all means, if no patient comes in who's pregnant, if that's what we're talking about within this respect, you know, if a patient who's pregnant comes in, they deliver, they've essentially graduated themselves, they will send them over to Tulane main campus. You know, my dad's, yeah, I see. My dad's a pulmonary, you know, critical care physician in a different state, you know, where they do have pediatric and they do have adult ICU. By all means, they move all of these pediatric OB patients away from the pediatric ICU because their problems are more involved in physiology. And then with regards to the, you know, when you guys are asking about pediatric advanced life support, in talking with the anesthesiologist and the stuff that I've done within research there, it's weight-based. And by all means, we're not going to have, if I have an OB patient who's under 72 pounds, I'll tell you, I'll write up the case report, but I don't think I have anyone who's small enough to actually fit the criteria for pediatric. And it comes out with they don't have an age cutoff for pediatric. So.
Well, the bottom line, we're covered. You have to document. We are covered, but you know, what is it that we want to do?
I think it would be great if we, you know, so I've been the person bugging everyone for emails regarding would you take on a pediatric OB patient consult? And we did. I've gotten different variations of it. I think it would be nice to have a list of physicians who will say, yes, I am willing to see it in an emergent situation, an urgent case, or not routinely at all. If we do have pediatric patients who are pregnant and 16 or younger, being able to set them up with social services as well as making sure that they understand that these services are not there should they want to deliver. I think we've had patients who have decided to pick a different hospital in the event knowing that maybe we don't have all of these services.
But again, it should a 16 or 17-year-old deliver here and something happens, are our consultants, you know, willing to treat them if something happens? And that's the thing that those departments have to decide what they feel comfortable in treating.
Yeah, I think you as the admitting physician better know that.
Yes.
And I don't think talking to the parents and letting them make that choice lets you off the hook. In other words, I don't know they're going to be capable of making that decision to understand what it means if something happened that's not in the line of what you're going to treat. You don't have the consultants, and we may have to delay and ship your kid in. It takes 2-3 hours and the kid dies, all right? If you knew that going in, and even if you tell them that, I'm not sure that resolves the problem for you. I mean, that's a risk you're taking on. If you know that there's some consult you cannot get in this hospital, and it's possible this kid gets that as an emergent situation, that's a risk you're taking on up front. And I don't know the answer.
Where they have to transfer everything to children because they don't have the specialties there for pediatric. I guess I'm just questioning, you know, besides any hospital that has full comprehensive patient feasibility, is what you're saying?
But that's a policy too. It's a policy. I think with policy we fix it. Well, I don't think the problem here is we don't have a policy.
Pediatric subspecialties typically rare. Like, I don't even know that Oshner has most of the pediatric subspecialties. It's more just we need to have some policy in place that says this is what we're going to be willing to do. And in smaller areas where they just have pediatrics, those pediatricians have to manage ICU patients sometimes. Like, they're not consulting a pediatric ID doctor in the vast majority of cases. But the city of Chicago probably has.
We're not going to be treating the pediatrics. That's not going to be staying here. Anybody 16 or under. So
Right,
what is the comfort level? What is the comfort level for you, people in your department, of someone who happens to be 16 or 17?
Right, but I think there's one thing to say, what are we going to do if situation arises? It's another thing to say, you can't treat an OB patient in this hospital because we don't have pediatric ID consult services available. Because if that's the case, then probably 99% of the children born in this country are not getting what is considered acceptable care. That's just not realistic. there needs to be some kind of a balance, and if we run into a situation
Yeah.
where it is needed, then you have to transfer to a higher level, whether that's.
Right, and they would do that. I mean, we
Yeah.
transfer anyhow adult patients for other reasons that we can't handle here.
And I mean, so
And-
if there's an OB complication that ends up arising and we see them and I get called and someone is physiologically adult, I'm going to document the correct tell myself I'd be comfortable with it. If you have an 11-year-old who's 80 pounds and they have to be on the ventilator, I'm going to be like, we need to get this person out of here immediately. I'm going to temporize, but that's just not.
We've also had, before, Tulane came out to Lakeside, we had a lot of patients being delivered there, and they would get sick. And where did those young moms had to come? Here. Now, they were over 18.
This is a true case many years ago, but I had a family call up and we transferred a 14-year-old who I operated on. She had a twisted ovarian cyst, which she had gangrene of the appendix, the ovary and the tube. But we didn't think twice of it. How would I have to think different now? Because it was in my scope.
Yeah, I mean, I think now remember, all we're talking about is if you're going to do the same thing that the subspecialist is going to do, you're fine. I mean, and you probably will. I mean, that's the thing. It's not that they practice a different medicine you know nothing about. It's just that they have the title, that they have the credibility, that they have. But if you're doing the same thing, that's the only risk you run. As long as you do what they would do in the same situation, you're fine. That's the only risk, that you won't do what they do, or you want in the training to know what they do because you haven't studied in 10 years and they have the latest thing that they studied 6 months ago. That's your only risk.
But what if that patient needed a pulmonologist afterwards, and they're 14? And Dr. Eisworth does not feel comfortable.
Well, that's the risk. That's the risk. If you know that going in, that's I don't know what to tell you, but I mean, as an attorney listening to this, I can see where that might be a concern. You can't call him. He's not going to come see that patient.
Right, but I mean, what I'm saying is it's the same risk as if somebody comes in for a procedure, an adult procedure, and it turns out that they have severe pulmonary hypertension that requires a place that has IV therapy, and we didn't know about it. We find it out during the procedure. We're going to have to transfer that patient out. If it's not an accepted, likely risk factor that it's a known thing, it's not like there's a 5% chance of X happening and we don't have the ability to handle it. If it's an unsuspected thing, you cannot say we're not capable of handling that because of the 1 in 100,000 chance of something happens. Because we're going to have cases where someone gets put under for a procedure and it turns out that they need to be immediately over somewhere that can do continuous IV therapy with pH. We don't do that. Myself, Tom, none of the pulmonologists are comfortable dealing with it. We're not the specialists. But you can't shut down the hospital because of these big what-ifs.
Right.
Those are known acceptable risks outside of the normalcy. And so for him to have to do a procedure or do an OB case, I mean, the hospital needs to have policies that are set so they can't take extremes, so it can't be as freaking.
All right. Well, let me just ask quickly. I know we've had a lot of difficulty transferring from the ER to University Hospital because it's constantly a battle, but has children's ever given us trouble with transfers? Probably not, huh? So some of this may be
not at the
academic.
age, you know.
Because if they're willing to take them emergently in the drop of a hat, a lot of this argument is academic because they'll take them.
Pediatric options in town are going to need even more space on this pediatric hospital boundary.
Right. So it's not as big an issue as you may think. Because as soon as we need
it's not, but it's still there.
Yeah.
And we've had issues where our consultants felt uncomfortable with that. Well, I don't know if anybody has anything to add, but I think it's a matter of, trying to, determine the policies that we have and what we feel comfortable with for the different departments as far as what they feel comfortable with. As I know, one time, Frank, you felt 18 and under you were not happy with, but, adolescents.
I used to treat the neonates here. Years ago.
Don't tell that to Dr. DePaula.
I'm totally happy. I'm totally comfortable. 16 and above.
All right. Any other questions? All right. Thank y'all for coming. Right now, we appreciate our consultants here. That's the situation. That's what we need.